not least, we're going to be welcoming Dr. Joe Martinez. Dr. Martinez is a former assistant dean of student affairs, and actually he was my assistant dean when I was a medical student, not many years ago at all. And now he is the associate dean for medical education. He's a wonderful medical educator, and in fact has a specific niche in abdominal and gastrointestinal emergencies. He speaks on the local, national, and international level. Welcome, and look forward to hearing from you.
Thank you, everyone. Can you hear me okay? Great, thanks. Well, let me just say what an absolute pleasure it is to be a part of this all-star cast. Certainly have a little imposter syndrome going on after these wonderful speakers, and I know that I learned a lot. But I also realize that as the last speaker, your brains are probably a little bit full. And so my objectives are actually pretty simple. I want to keep you away from this gentleman. So this is an actual billboard that I saw as I was on my way to a talk that I was giving, and I was so excited by it, I actually stopped the Lyft driver and had him pull over so I could run back and take a picture of this. But this is sort of what we're up against as emergency physicians. These people are out there. He and his brothers and sisters are looking at our charts and our cases and actively trolling, trying to find reasons for us to be sued. So George talked a little bit about this study at the very first talk this morning. So this is looking at aortic dissections, but also looking at ruptured AAAs. And what you can see here is, if you think about who's getting sued for this, really it's us. Far and away, it's emergency practitioners that are being the ones that are on the front lines for these lawsuits. And George talked about this a little bit as well too, but why are we being sued for this? Well, we're not being sued for negligent surgery or lack of informed consent or intraoperative complications or technical errors or postoperative complications, negligent postoperative care. Maybe a little bit on this, but what we're really being sued for is this failure to diagnose and treat and delayed diagnosis and treatment as well. What I can also tell you is that for those of you that don't practice in a tertiary care center, you may think to yourself, well, maybe my delayed diagnosis is because I have to transfer somebody someplace else. And so if you actually look at these cases, these are really not due to delays in transfer. They're really focused on the delays in making the diagnosis and starting the appropriate treatment. So you really can't defend yourself with this delay in transfer argument. Now, when we look specifically at AAA verdicts, so ruptured AAAs, what happens here? About 48% of them, as George said, end up in favor of the defendant, 30% in favor of the plaintiff, and 22% settle. But what I can tell you from reviewing a lot of these cases is that the time from onset of being notified that you're being sued until either it settles or it goes to trial and there's a verdict, that's a very, very stressful time. And Mike Bressler talked about this a little bit as well, that people's whole lives are disrupted by this. They end up getting divorced. There's just a significant amount of stress. So it's better not to get sued in general. What happens when there is a verdict? The mean amount when there was a settlement made or where there's a verdict in favor of the plaintiff was $1.8 million. But if you look at it, the range was $17,000 to $68 million. And if you are an American football fan, you probably saw the news that Aaron Rodgers, who was the most valuable player in the NFL last year, extended his contract and became one of the highest paid players in the league. And he's only making $49 million next year. So even he couldn't cover a $68 million verdict. Now, let's look at a couple of these studies. So this one is a few years ago. It looked at misdiagnosis of ruptured AAAs. And what they found was that about 42% of cases were misdiagnosed at first presentation to a healthcare provider. This study came out just last year, misdiagnosis of ruptured AAAs in 2021. And look, we're doing a lot better. We're down to 39% are misdiagnosed. All right, well, let's dig into these just a little bit more. If you look at this first one, this was an older study. So look, it included papers from the 60s, the 70s, the 80s, the 90s. It included both emergency departments and outpatient clinics. And it really, ran the gamut of all sorts of different people. So it included emergency physicians, surgeons, internists, general practitioners, and sort of the catch-all first registered medical practitioner to see the patient. So you can understand that with this wide variety that maybe there's a lot of misdiagnosis because people aren't trained in emergency medicine. They're not specifically thinking about this. So what were the misses? When you look at how these patients presented, again, looking at those red arrows, you can see our classic triad of ruptured AAA. So abdominal pain, shock, pulsatile mass. And if you look at the percentages, you can see that even if you just look at one component of the triad, the best case scenario is that you're catching about 60% of the cases. And I want you to look at what's circled there. This is something that I've been talking about now for almost 20 years, and it keeps cropping up, as you'll see in the next study, that one of the top misdiagnoses for ruptured AAA is renal colic, so kidney stones. And that's going to be one of our take-home points. Again, I know your brains are getting full here at the end of the day, but one of our take-home points is going to be the misdiagnosis of renal colic as an actual ruptured AAA. So let's look at our next one. So this was one in 2021. These were emergency departments and emergency physicians. But the caveat here is that although they all had CT readily available, they did not have point of care ultrasound readily available. And that's going to be take home point number 2. And that's why it's in green. So this is one of the best ways that we can make this diagnosis in a timely fashion. And you can see that even though this was emergency physicians and emergency departments, we didn't do a whole lot better. Our miss rate went from 41% misdiagnosed down to 39%. So also look at this. It's really important to make this diagnosis. First of all, 5.5% of the people that were missed were actually discharged home. So that's really bad. Those are lawsuits waiting to happen. And 10% were diagnosed at autopsy only. The rest were diagnosed in the hospital. So you could say, well, it's okay if you diagnose them in the hospital, that's probably okay, right? It's a little bit of a delay, but not too bad. But when you look down at the bottom there, when people were misdiagnosed in the emergency department, their mortality rate was 74% compared to 62% if the correct diagnosis was made in the emergency department. And if you excluded the people that they decided to offer palliative care to, the numbers get even worse. In the misdiagnosis group, the mortality rate was 65%, and it was 20% lower in the correct diagnosis group, 46%. Again, looking at the symptoms they presented, very similar to what we saw in that older study: abdominal pain, back pain, syncope. So sort of our classic symptoms. And you can see that when people presented with classic symptoms, the correct diagnosis was made much more commonly. So about 80% if they presented with abdominal pain versus 52% were misdiagnosed. But look at when they presented with atypical symptoms, right? So if you had vomiting as your symptom, you were misdiagnosed in 32% of those cases. And if you presented with dyspnea as well, you were significantly more likely to be misdiagnosed. So you have to think about those atypical symptoms as well. Now, look again at what the ultimate misdiagnosis was, right? So again, remember, these are older patients. And so what happens in these older patient group is if you actually look for a diagnosis, you can often actually find that diagnosis, right? And certainly when it comes to ruptured AAA, if you go looking for that diagnosis, that should be a readily findable diagnosis, right? We have many different ways to find a ruptured AAA, whether it's looking with bedside ultrasound, whether it's looking with CT, whether it's getting some other advanced imaging, or whether it's going to the OR. And again, here comes our old friend. So remember, this is a much more recent study, all done by emergency physicians in emergency departments, and we're still seeing kidney stones crop up as one of the most common misdiagnoses. All right, so how do we start to really make an impact on this? I don't think 3% is really a very impressive improvement over the course of these years. How do we really make an impact? Well, certainly it's important to know the classic, right? So if you have that classic triad, abdominal pain or back pain or flank pain, you have a pulsatile mass, or you have hypotension or relative hypotension, you present with syncope, those are the ones that you absolutely can't miss. I wanted to make a small aside here about the relative hypotension, because I think this is something that we teach very frequently and people intuitively know it, that if your blood pressure normally is 180/100 and you come in and you're 120/80, that you are relatively hypotensive. And that's just as important as absolute hypotension. But this was something that I saw in a case just a couple of years ago where at deposition, the emergency physician was asked, well, doctor, did you have access to the electronic medical record? And he said, yes. And they said, did you have the ability to go into the record and look at their old blood pressures? And they said, yes. And they said, well, doctor, if their blood pressure, if I told you that their old blood pressures were all above 180 systolic, would you agree to that? And he said that he hadn't looked. And then when they said, well, I can show you this graph of all of their old blood pressures showing that. And then when you hear now that their blood pressure at presentation was 120, does that make you more concerned? So this is something that really the plaintiff attorneys have latched onto as well. And, looking at a graph of their blood pressures where all of the blood pressures are up here, and then the day that they see you, it's down here, is a really damning visual representation of this concept. We have to know the classics, but we also have to know the classic misses, right? So we've talked about this a couple times now, that kidney stones is one of our classic misses. Low back pain is another common one. And remember, in an elderly patient, if you go looking for the cause of abdominal pain, you probably are not going to find NOS. You're going to actually find a cause for their abdominal pain. And certainly if it was a ruptured AAA, you should be able to find that cause. The other classic miss is a groin pull. So patients come in and they say that they pulled their groin. And that's because as the AAA ruptures into the left retroperitoneal space, it starts to press on some of the nerves that run down into the leg and into the sciatic area as well. And so people will come in with either sciatic type pain or thigh or groin pain. And that's one of our classic misses for ruptured AAA. Then you have to know the atypical presentations as well. So remember, we showed in that chart nausea, vomiting, and dyspnea. You were much more likely to be misdiagnosed if these were your presenting symptoms. We talked a little bit about groin pain and leg pain. This picture here is showing you the scrotal sign of Bryant. So patients will infrequently, but well described, present with either testicular pain or non-traumatic ecchymosis of their groin. So if you see a patient that comes in that looks like this, it's one thing if they say they were just kicked in the groin or they had a straddle injury while riding a bicycle or a motorcycle or something like that. But if they come in and they say, I just woke up with this, your first ultrasound should not be of the testicle. It should really be of the aorta, because this is well described in the literature that this can be the first sign of a ruptured AAA. How else do we improve? Well, it's important to do better physical exams. So I don't think many of us are going to miss this AAA. If you see a patient in front of you and you can actually see their AAA pulsing, that's not something that we're going to miss. But how about actually palpating for a AAA? So this looked at patients that had abdominal palpation to detect aortic aneurysm. And again, if you're in a country where you don't use girth and you don't use centimeters, the cut point for them was 100 centimeters, which is approximately a 40-inch waistline, as you can see there at the bottom. So that's a fairly robust waistline. Even with the rising epidemic of obesity, a lot of people are not going to be above 40-inch waistlines. And what they found in the study was that the sensitivity for palpating an abdominal aneurysm was 91% if their abdominal girth was below 100 centimeters, and 100% if it was below 100 centimeters and the AAA was 5 centimeters or larger, which are really the ones that we want to catch, right? But importantly with this, this is something where you have to really target the physical exam a little bit, and you have to think about what you're looking for. So very similarly to when you're listening to a heart and somebody that came in with syncope, you're listening for very specific things, right? So you might say, well, this is an older patient with syncope. They could have aortic stenosis. I really want to make sure I listen in the aortic area, and I'm listening for an aortic stenosis murmur. Similarly, in these patients, you need to think to yourself, this is an older patient. They could have a AAA. I need to actually palpate for a AAA. I need to be above the umbilicus. I need to be a little bit left of the midline, and I need to really see if I can feel something here. It's not just the little, press all over the abdomen and see if it's soft, see if there's any areas of tenderness. Importantly, we need to have better cognitive skills. So again, this is not a very difficult diagnosis to make, right? This is usually something where you just didn't think about it, or the patient looked too good. You couldn't believe they could have a ruptured AAA. So if they're over 50 with abdominal pain, especially if they're men, especially if they're smokers, especially if your discharge diagnosis is kidney stone or low back strain or abdominal pain NOS, you really have to think to yourself, could this be a ruptured AAA, and should I go look for it? And we have to use better use of our tools. Point of care ultrasound is widely available in many places now. And even for somebody like me that really didn't grow up being trained in ultrasound, learning how to look at an aorta is a very simple process. It's something that you can learn in the course of an afternoon, and you can really demonstrate proficiency with it. I reviewed a case really not that long ago where the emergency physician actually made the diagnosis of ruptured AAA, but he made it on CT scan. And it took 4.5 hours for that patient to go to CT scan. And the whole point of contention of that lawsuit was the time it took to get CT scan. And again, in the deposition, the plaintiff attorney said to the physician, "Doctor, did you have access to an ultrasound machine in the emergency department?" And they said, "Yes." They said, "Doctor, do you know how to look at an aorta by ultrasound?" And the doctor said, "Yes." And I'll never forget this. The question next was, "Doctor, was there something systemic that prevented you from looking, such as a widespread power outage in the hospital where you couldn't plug the ultrasound machine into the wall?" And the doctor said, "No." And so then they said, "Well, doctor, if you had done a bedside ultrasound and you saw that this patient had an aneurysm, would you have called a surgeon, or would you have at least prioritized them to get to CT quicker?" And the doctor admitted that they would have, and that case settled. And when the doctor was asked why they didn't do the ultrasound, their response was, "The patient looked too good. I didn't think it could be a ruptured AAA." So we've got to be better about using the tools that we have in our armamentarium. So in summary, when we're thinking about ruptured AAA, this is something we continue to miss, and we continue to delay the diagnosis. And even after many, many years of sort of teaching whole generations of learners that people masquerade as kidney stones when they really have ruptured AAAs, we continue to make that misdiagnosis. We've got to be a little bit better about doing that. We've got to take care of this. And luckily, this is a really easy fix. If you think about the diagnosis, examine them specifically, looking for that diagnosis, and get your bedside ultrasound, order your CT, you'll make this diagnosis. This is not a challenge to make. It's only a challenge to think of. Now, with that in mind, let's switch to a different diagnosis that is a little bit more challenging to make. So again, my objectives for this part of the talk are very simple. I want to prevent your patients from developing this. So dead bowel, large amounts of bowel resection with, assuming they survive this surgery, they're probably going to have some crippling effects. And again, I want you to stay away from this gentleman for the rest of the talk and the rest of your career as well. So this is acute mesenteric ischemia. And the reason I'm showing you a picture of a wastebasket here is because this really is what I call a wastebasket term, where it encompasses a bunch of different entities. We lump them all under the name mesenteric ischemia. And that's one of the pitfalls in making this diagnosis, is that we really treat all of these the same, and they're very, very distinct. So there's 4 types. There's a superior mesenteric artery embolus, superior mesenteric artery thrombosis, mesenteric venous thrombosis, and non-occlusive disease. And these all present very differently. So our classic is the SMA embolus, and this usually presents in somebody with underlying cardiac disease, which on a board exam or an in-training exam is always, 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 always atrial fibrillation. And yes, in real life, that's true too. If you have atrial fibrillation and you have acute abdominal pain, you need to go looking for an SMA embolus. But in real life, it's not that simple either. The underlying cardiac disease can be anything that predisposes you to stasis on the left side of your heart. So this can be certain valvulopathies. It can be things like really bad advanced heart failure, where your EF is 10% and the left side of your heart is just doing this instead of pumping effectively. These patients present with acute onset of pain as they shower that embolus south. And your bowel is actually really smart. It doesn't want to work very hard when it's not getting enough blood flow. So the first thing it tries to do is it flushes itself out. So it gets rid of everything in the bowel so it doesn't have to work so hard. So patients present with vomiting or diarrhea or both. And that's why one of the classic misdiagnoses here is gastroenteritis. So here's our pearl for this part. 1/3 of patients that have an SMA embolus will have had a prior embolic event. So here's a patient, they've got a nice big clot in the SMA, this big embolus here. And oh, look, they also have a ischemic stroke, as we heard from Dr. Marcolini earlier. Now, this may not happen at the same time, but you may know that the patient has had a stroke before. You may also see that they've had a revascularization of their lower extremity in the past from an embolus, or maybe you have an old CAT scan that shows that they've had a renal infarct or a splenic infarct in the past. Those are all clues that are going to help you make this diagnosis. So here's what it looks like on angiogram. You can see that the SMA is stumped here with a little bit of sparing of the proximal SMA as it tapers for the clot to get it lodged, and some sparing of the proximal small bowel. Here's what it looks like on CT scan. This is something we're going to see more commonly. And as as one of our previous speakers mentioned, it's really important to look at your own images. And again, if you're going to look at your images, I really recommend that you look at these sagittal images here. And what you can see is you can see the aorta, you can see the celiac axis here, which has a clot in that as well. And then you can see this abruptly stumped SMA here. So if you're not used to looking at CT angiograms for this, start with these sagittal images and then go to your axial images. But make sure that you look at your own images. We had another case not that long ago where the patient came in and they had an SMA embolus. And when the radiologist was protocoling the CT, they realized that the patient had been at another institution within the same hospital system earlier in the week. And when they went back and looked at the images from that hospitalization, they realized that there was evidence already that they had mesenteric ischemia. They had some renal infarcts and a splenic infarct, and they had a thrombus in the aorta already. So radiologists are human as well. They can miss things. I have to believe that if the emergency physician had looked at that scan themselves, they could have picked up some of these findings and maybe specifically questioned the radiologist about them. SMA thrombosis is what I call acute coronary syndrome of the gut. So we've talked about ACS a lot today. This is ACS of the gut. These are patients with your classic vascular risk factors and typically are smokers. Most of them will have a history of intestinal angina. So remember, when you eat, that's a stress test for your gut. So if you have flow limiting stenosis in your SMA, you can't appropriately increase your blood flow to your gut and you have postprandial pain and you start to lose weight. You can see in this picture, this patient is very cachectic. I reviewed another case a couple of years ago where a patient had acute mesenteric ischemia during their hospitalization, but they had been either to their primary care doctor's office or to that hospital maybe 8, 10, 12 times over the last 3 years, being admitted for intractable nausea and vomiting. They were labeled as having gastroparesis, even though they didn't have they had a normal gastric emptying study during one of their hospitalizations, and people didn't think of chronic mesenteric ischemia. And when the patient was admitted to the hospital for the final time, when they finally had acute mesenteric ischemia, their weight was all the way down to 93 pounds from almost 200 pounds 3 years earlier. So this should be in the differential of your patients you're seeing that have a lot of weight loss. So with SMA thrombosis, specifically ask people about intestinal angina in the last few months. This is what it looks like on angiogram. You can see that there's no little stump of an SMA because it takes it off right at the origin of the SMA. And you can see here on the CT scan, here's the SMA, which has a big clot in it, but look at all this other vascular disease. You can see the celiac axis is calcified. The SMA is calcified. There's calcifications all through the aorta. So this is a patient that has a lot of vascular disease. And again, you can pick this up easily yourself looking at your own images. Mesenteric venous thrombosis is what I call the oddball. This is typically less severe pain, and it's usually younger patients. Look at this, 53 years old as opposed to 78 years old with the other types of mesenteric ischemia. Because it's a venous problem, the time course can be longer, days to weeks. And this is one of the reasons that we miss this particular type of mesenteric ischemia, is because it happens in younger people. And when they come in and we think, you know, they've been having symptoms for 14 days or 21 days. This can't possibly be mesenteric ischemia. It can be mesenteric ischemia. It's just typically mesenteric venous ischemia. This is what it looks like. So at laparotomy, you can see how really edematous and congested this bowel is, because this is really an outflow problem rather than an inflow problem. So here's the pearl for this. 1/2 of all patients with mesenteric venous thrombosis will have a personal or a family history of venous thromboembolic disease. So DVT or PE, as we've been talking about this morning. And that's because these patients are often hypercoagulable. Maybe they have factor V Leiden mutation or antithrombin 3 deficiency. Maybe they're on oral contraceptives. But specifically asking patients about this will help you make this diagnosis a little more readily. Here's what it looks like. You can see they've got a big clot here in the superior mesenteric vein and the extrahepatic portal vein. They've got some bowel wall ischemia down here. And this patient went to laparotomy. You can see what normal bowel looks like up here. And you can see really, again, congested, blood-filled bowel wall in there. Then the final type is non-occlusive mesenteric ischemia, which I call the dreaded, because these are the patients that are really sick for other reasons. So these are low flow states. They may just come in with abdominal distension or GI bleeding. Let's say you intubated them for sepsis and they're in your department waiting for an ICU bed, and all of a sudden their belly starts to blow up. They start to pass bloody stools. But the other group that I want you to think about this in is your dialysis patients. So a lot of patients will experience intradialytic hypotension, where their blood pressure drops during dialysis. They develop vasospasm of their mesenteric vasculature. And usually as dialysis ends, fluid shifts, move around again, their blood pressure starts to come back up and that vasospasm goes away. But in a significant proportion of patients, that vasospasm never goes away. So persistent abdominal pain after dialysis should always make you think about non-occlusive mesenteric ischemia. Here's what it looks like. Again, on angiogram, you can see that the SMA is full, but all these branches are little scraggly, low caliper branches. And if you compare what a normal SMA looks like, you can really get a better appreciation of that, of how much vasospasm there is of all these branches. And this is why the radiologist called that a pruned tree appearance. You can see it on CTA here as well, really narrow caliber. Again, this is a selective mesenteric angiogram down here. And here at laparotomy, you can see that they've got some normal bowel, and then they've got areas that are very ischemic looking, some areas of edematous bowel. And then they started to lavage the abdomen with warm saline and give some intra-arterial vasodilator, and the bowel improves very quickly. So are we missing mesenteric ischemia? If you look at the first study from the UK, a database of their general practitioners, they estimated the incidence at 0.63 cases per 100,000 years. Now, the diagnosis of mesenteric ischemia was based on questionnaires of the treating physicians and a post hoc review of the medical records. Compare that to a different study done in Sweden, where they had an 87% autopsy rate rather than relying on questionnaires and medical records. And they found that the incidence was 12.9 cases per 100,000 years, 20 times higher than in the other study. So that makes me think that, yes, we probably are missing this. And why are we missing this? So first of all, we think it's a really rare diagnosis, right? But if you look again at this chart here, and mesenteric ischemia is this black line here, you can see that as we get to be around 65, the incidence is higher than that of ruptured AAA, which we just talked about. As you get to about 70 or 75, it gets higher than acute appendicitis. And as patients get above the age of 80, it's much higher even than acute pancreatitis, things that we think are much more common than mesenteric ischemia. And this is called the zebra retreat. So this means that we think it can't be the diagnosis because the diagnosis is really rare and we can't be the one that's actually seeing it and diagnosing it. So again, another cognitive error that we need to avoid. So remember, they're not all going to present the same. Remember, it's a wastebasket. There's different types of mesenteric ischemia and they all present differently. All right. You also have to think about, are they presenting classically versus atypically? So again, if you look at this, think about our classic triad here. You've got abdominal pain, which is pretty good, gets anywhere from 60 to 100. But if you narrow that down to what we always think of as the classic pain out of proportion to exam, really that's like a coin flip, right? 45 to 54% of patients will present with that. And then if you add in the gut emptying, right, you're starting to get things that are down in the 18% range, 40% range. So your classic triad, again, very unlikely to present with the classic triad. So why are we missing it? Well, we keep relying on biomarkers. Look at our lactate levels here, sensitivity of 33 to 100%. And I will tell you that these 100% were poor quality, older studies. Sensitivity lactate is really thought to be around 60% for this disease process. So just highlighting that a little bit more, looking at studies where the lactate is normal. Here's a group of patients where the diagnosis was made in a timely fashion, which they defined as less than 24 hours, or in a delayed fashion, which was over 24 hours. And you can see that the people that were diagnosed that took 24 hours to make the diagnosis, 62% of them had a lactate level less than 2 at presentation. The next reason we're missing things is that we're doing the wrong test and we're not telling our radiologist what we're looking for. This is, I think, a really cool study where they looked at the performance of board certified radiologists in reading CT scans that were subsequently proved to be mesenteric ischemia. And what they found was that radiologists get it wrong about 14% of the time. And it does span some of the things, with non-occlusive mesenteric ischemia being the biggest chunk there as well. But importantly, it also is, their rate is also impacted by whether the right CT scan was ordered. So if you look at this, CTA is this group, and PVP stands for portal venous phase. So at University of Maryland, when you order a CTA for mesenteric ischemia, you get a non-contrast, you get a CTA of the arterial phase, and you get a portal venous phase. And that is often referred to as either multiphasic, triphasic, and then split bolus goes in there as well. And so they really perform better if they get the right type of contrast and the right timing of that contrast, as opposed to getting something like an unenhanced CT where the incorrect diagnosis rate is 40%. So their conclusions from this study were that the possibility of acute mesenteric ischemia was taken into consideration prior to the study in only about a third of the study cases. And if the on-call radiologist didn't know that you were concerned about mesenteric ischemia, they were significantly more likely to miss the diagnosis compared to when they were specifically told that mesenteric ischemia was on the differential. I like that they say these are the main findings and reflect the everyday situation in the emergency department. And they furthermore come up with the conclusion that the possibility of acute mesenteric ischemia should be clearly stated in CT referrals in order to ensure that they protocol the CT scan correct. And I like this, remind the radiologist to pay particular attention to the intestinal findings and the patency of the mesenteric vessels. The next step is timeliness, right? Are we doing this in a rapid fashion? So if you look at this, this is a case that, again, that I reviewed of a patient that had mesenteric ischemia. They got to the emergency department at 10:40 in the morning. They had labs ordered. The decision was made to send them to ultrasound at noon. They went to ultrasound, they came back. Mesenteric ischemia started to be thought of a little bit more highly. And so some additional labs were ordered, a lactate and a D-dimer. The CT was ordered at basically 1:30 in the afternoon. Patient lost their IV access, had to have new IV placed. Surgery saw them somewhere in here, and they were actually ordered to go to the OR and finally went to the CAT scan at 4:38 in the afternoon. And of course, this is in the time of COVID, so they had to have a COVID test done before they got to the OR, and got to the OR at 16:30. And the biggest crux of this entire case was this time frame between when the CT was ordered and when the patient went to CT scan, right? So one of the take-home points for this is, should we have an acute mesenteric ischemia alert, right? We have stroke alerts where patients go directly to the CT scanner to get their imaging performed in a timely fashion, right? We have STEMI alerts where patients are brought directly from hospital, from pre-hospital providers all the way to the cath lab if they're having a STEMI on their pre-hospital EKG. Should we have acute mesenteric ischemia alerts? It is a stroke of the intestinal system. It's a time-sensitive diagnosis. So rather than just queuing this patient up behind all the other CT scans that you have ordered that day, where patients are getting them, to clarify a diagnosis or on a fishing expedition, should we have these AMI alerts where if you think it's mesenteric ischemia, you actually prioritize them and they get brought in a much more expedited fashion to the CT scanner? Something to think about as you go back to your own facility. Well, we talked about all the reasons why we get this wrong, but let's talk about how we get this better. So know the patterns and the clues. This is something that I try to teach our trainees, and I hope that they learn. And we think through this when we have a patient that comes in that we're concerned about mesenteric ischemia. Ask them about those clues that we talked about in those different types of mesenteric ischemia. Prior embolus, previous intestinal angina, personal or family history of venous thromboembolic disease, or are they a dialysis patient? Be thoughtful about your process, right? We talked about this a little bit with Ruptured AAA, that you have to sit down and think about it, right? So for all of you that are listening that are trainees or are early in your career, this is why I really encourage you to write your notes while the patient is still in the emergency department, rather than jotting them down, jotting some clues down, and then writing them after your shift. Because as you sit down to write the note, sometimes things become a little bit more clear, right? So as you're writing your ACS note and your gestalt is that this patient has low risk chest pain and they go home and you start to document their history and you write, well, they had exertional chest pain and they got a little sweaty and then they threw up and they have a family history of acute coronary syndrome. You start to think, well, maybe this isn't as low risk as I thought it was, right? So in this case, as you're writing it down, you can think through those clues we talked about on the last slide. Your EMR can pull in important information. Maybe you find out they have a history of AFib, that you had forgotten about. And that's enough to make you sort of rethink this, but actually being deliberate about your process helps avoid some of those cognitive errors. Be cautious with your labs. So I would agree that if you have a patient with abdominal pain, you're concerned for mesenteric ischemia, their lactate is up, they should get a CTA. But just because their lactate is not up doesn't mean that they shouldn't get a CTA. And remember not to be misled by labs. So in this one study, really almost half the patients in the study that had mesenteric ischemia also had an elevated troponin. And how did that impact their care? If they were referred to a cardiologist instead of being referred to a surgeon, their in-hospital mortality was 60%, right? So much higher than when they were sent directly to surgery. So be cautious that your labs are either not preventing you from doing a test or are swaying you in the wrong direction. Order the CT, the right CT, and tell your radiologist. So put something specific down that says, this is an older adult with sudden abdominal pain and atrial fibrillation. I'm concerned for mesenteric ischemia. They'll get the right protocol CT, and then they'll do all sorts of cool stuff with it. They'll reformat it. They'll do these 3D imaging, and you can, again, see these very clearly, this SMA embolus with this stumped SMA here. As we're thinking about big pictures of how to get better. So this is looking at sort of individual patients. There's a lot of data out there now that says that dedicated stroke centers for mesenteric ischemia actually improve your bowel and your life outcome. So this is Beaujon Hospital in France, where they have an intestinal stroke center. Again, this is a very big picture stuff, right? But they do great work where they're actually able to get people in a very expedited fashion worked up for this, taken to the OR, where they can have things like embolectomies performed as well. Even if you don't have a dedicated stroke center, many of us have these hybrid ORs now where you can do interventional therapy at the same time as you're preparing for traditional open therapy or even damage control surgery. There's lots of data out there in the surgical literature about ways to approach this with endovascular therapy first. And the mantra is really becoming revascularize first, resect later. So try to reperfuse the bowel and then damage control resection later. And you can do really cool stuff like interventional therapy here, where you stent this abruptly occluded SMA that you can see here, that you can see up here as well. All right. So when you're thinking about mesenteric ischemia, consider it seriously. Think about the history and the clues. Really think through these clues for your patients. Use your labs properly, and most importantly, order the right CT quickly, and make sure that you're telling your radiologist that you're concerned about mesenteric ischemia. And when you make the diagnosis, you absolutely have to be multidisciplinary about this. This is something that needs a vascular surgeon, a general surgeon, an intensivist, an interventional radiologist. And I understand that many of us practice in places where we don't have all of those, but your patient, to be appropriately cared for, is most likely going to need to go to a place where they can have access to more than just a general surgeon. So with that, hopefully we're close to being on time. I'll say thank you, and I'll be happy to take any questions or stay afterwards if people have to drop off.
Thank you, Joe. There are a couple of questions, but in the interest of time, let's just do one quick one regarding CTA of the abdomen. Is there something that the CTA will show you that a CT with contrast will not? So if they obtain a CT with contrast, does that rule it out? And then what about non-contrast CTs, especially for patients?
I'll take the first question first. So it really is important that it be protocoled as a CTA because you're going to have fine enough cuts that you can actually see the mesenteric vasculature. And it should ideally be done in multiple phases, meaning the arterial phase, which is the traditional CTA, but also with portal venous phase imaging, so you can look for the effects on the bowel wall as well. With just a traditional CT with contrast that is not protocoled as a CTA, typically the cuts are not fine enough to be able to do that. You may get lucky and pick up, especially if they have really advanced vascular disease, if they have an SMA thrombosis with a lot of bad vascular disease, you may pick it up. But similar to what Dr. Willis was talking about a long time ago in this conference, where he said, when you're looking for a PE or a dissection, you really want to protocol it as a dissection. It's the same thing here. You really want to be able to look specifically at the mesenteric vasculature. Otherwise, you're really just looking for the secondary signs of mesenteric ischemia, so the bowel wall findings. And with respect to your second question, an unenhanced CT scan is almost worthless in these cases, unless they have very advanced disease where they're already having a lot of bowel wall damage, and they may have perforation, they may have pneumatosis. You may be able to see some of that on a non-enhanced CT, but otherwise it's really essentially a useless study.
Thank you very much.